Okay, let's unpack this. First up, Barrett esophagus.
Mm-hmm.
So the mechanism is listed as chronic GERD leads to replacement, metaplasia, of non-keratinized stratified squamous epithelium with intestinal epithelium, non-ciliated columnar with goblet cells.
Okay, so let's break that down. Basically, you've got long-term, pretty severe acid reflux, right?
Yeah.
Stomach acid keeps splashing up into the esophagus.
Yeah, that chronic heartburn feeling.
Exactly. And over time, that acid damages the normal lining of the esophagus. The body tries to adapt to protect itself.
So it changes the cells.
It does. The normal squamous cells, they get swapped out for a different type cells that usually live in the intestines. Columnar cells with goblet cells mixed in, it's called metaplasia.
A protective change, but risky.
Precisely. It handles the acid better, but those new intestinal type cells have a higher risk of eventually turning into esophageal cancer, Adenoma-carcinoma. It's a serious warning sign.
And we have a story that illustrates this perfectly. It came from a listener.
Yeah, this was powerful. She had had awful heartburn for years, felt like food was getting stuck, had a cough that wouldn't quit, her voice got hoarse.
Classic GERD symptoms then.
Textbook, she even started losing weight. Her new GI doc did an endoscopy, saw this patchy, kind of orange-looking tissue.
Not the normal pink lining.
Not at all. Biopsy confirmed it. Barrett's esophagus. Specialized intestinal metaplasia. She was, understandably, relieved to finally have an answer for all those symptoms, but also terrified about the cancer risk.
Wow. Really drives home the importance of checking out chronic GERD.
Absolutely. Endoscopy with biopsy is key. If they find dysplasia, that's even more concerning, needs close monitoring or even eradication therapy.
Okay, let's switch gears. Next condition. Acute gastritis secondary to NSAIDs.
Ah, yes. Very common issue.
The mechanism is decreased prostaglandin E2 leads to decreased gastric protection. Short and sweet.
It is, but packs a punch. So NSAIDs, think ibuprofen, naproxen, that kind of thing. People take them all the time for pain, inflammation.
Over-the-counter staples.
Right. But they work by blocking certain chemicals, including prostaglandins. And one specific type, PGE₂, is really important for protecting your stomach lining.
How so?
PGE₂ helps maintain the mucus barrier, blood flow, stuff that defends the stomach against its own acid. When you block PGE₂ with NSAIDs, that defense weakens.
Leaving the stomach vulnerable.
Exactly. Vulnerable to acid damage, inflammation, gastritis, acute gastritis.
And we heard from a caregiver about this, her father.
Yeah, this was a tough one. He was a retired carpenter, took ibuprofen every day for years, achy knees,
Common scenario?
Very. Mentioned heartburn sometimes, but nothing alarming. Then one morning, bam, sharp, burning stomach pain, started vomiting stuff that looked like coffee grounds.
Oh, that's digested blood. He made emesis.
That's right. Rushed him to the ER. First thing they asked about was medications. Endoscopy showed acute gastritis, erosions.
And the culprit was the ibuprofen.
Directly. The doctor explained how it had just slowly worn away his stomach lining by cutting down that protective PGE₂. Stopping the NSAID was step one, obviously. Then meds like PPIs to heal it up.
A real wake-up call, especially for older folks who might be on NSAIDs long-term.
Definitely. Sometimes prophylactic PPIs are needed for high-risk patients.
Okay, next up, celiac disease.
An autoimmune condition.
The mechanism reads, autoimmune-mediated intolerance of gliadin, found in wheat, leads to malabsorption, distal duodenum, proximal jejunum, steatorrhea.
Right. So celiac isn't just an allergy or sensitivity. It's your immune system actually attacking your own body.
Triggered by gluten.
Specifically, a component of gluten called gliadin found in wheat, barley, rye. When someone with celiac eats gluten, their immune system reacts by damaging the lining of the small intestine.
Which part specifically?
Mostly the distal duodenum and the proximal jejunum. That's where a lot of nutrient absorption happens. So damage there leads to malabsorption.
And that causes the symptoms.
Exactly. Things like chronic diarrhea, greasy stools, that's the steatorrhea, weight loss, fatigue, vitamin deficiencies, even things like mouth sores, those aphthous ulcers.
We got an email about this from a parent. A long struggle.
Yeah, this was about their daughter, Lily. Around age 3, she just wasn't thriving. Constant diarrhea, belly bloating, poor growth, pale.
Sounds exhausting for everyone.
Terribly. They saw multiple doctors. Finally, blood tests, including the anti-tissue transglutaminase IgA, pointed towards celiac. An endoscopy confirmed it.
What did the endoscopy show?
The doctor showed the parents pictures. Her intestinal lining, normally full of little folds and villi to absorb nutrients, was all flattened and damaged. The biopsy clinched the diagnosis.
So the treatment.
Lifelong, strict gluten-free diet. That's the only way. But the change was dramatic. Within weeks, Lily started getting better. More energy, tummy settled down, started gaining weight. It was life-changing.
Wow. Shows how critical that diagnosis is.
Yeah.
And the HLA-DQ-key DQ8 testing can help rule it out too, right?
Yes, it's useful for ruling it out if negative.
Okay, let's move to a complication of IBD, fistula formation in Crohn disease.
Right. This is a key differentiator for Crohn's.
The mechanism is simply transmural inflammation.
And that one phrase explains it all. Crohn's disease causes inflammation that goes through all layers of the bowel wall. Transmural, from the inside lining straight through to the outer surface.
Unlike ulcerative colitis, which is more superficial.
Exactly. UC typically affects just the inner lining, the mucosa, but Crohn's goes deep. And that deep inflammation can literally tunnel through the tissue.
Creating a fistula, an abnormal connection.
Precisely. A tunnel connecting, say, one loop of bowel to another, enteroenteric, or the bowel to the bladder, intravesical, or even bowel to the skin, enterocutaneous. Perianal fistulas are also common.
We heard from a patient dealing with this.
Yeah, someone with known Crohn's. They were used to the usual pain and diarrhea, but then developed recurrent UTIs. And the really weird thing, passing gas bubbles in their urine.
Pneumaturia. That sounds alarming.
It is. The doctor immediately suspected an enterovesical fistula, a connection between the bowel and bladder, explained that the transmural inflammation had basically burrowed through.
How is that managed?
It often requires a combination of medical therapy for the Crohn's like biologics or immunosuppressants and sometimes surgery to repair the fistula, especially if it's complex or not responding. Imaging like CT or MRI helps diagnose it.
Okay, fascinating but tough complication. Next, Meckel diverticulum. Back to developmental issues.
Yes, a congenital anomaly. Actually, the most common one in the GI tract.
The mechanism is persistence of the vitelline omphalomysenteric duct.
So during development in the womb, there's this tube connecting the baby's gut to the yolk sac. That's the vitelline duct. Normally, it disappears completely before birth.
But sometimes it doesn't.
Right. If a little piece of that duct hangs around, it forms a small pouch or outpouching on the small intestine. That's the Meckel diverticulum.
Just a little leftover pouch. Does it always cause problems?
Often, it's totally asymptomatic. People never know they have it. But sometimes it contains ectopic tissue that doesn't belong there.
Like what?
Most commonly, stomach tissue or pancreatic tissue. And that ectopic stomach tissue can produce acid right there in the small intestine.
Which can cause bleeding.
Exactly. Painless bleeding is the most common symptom, especially in young kids. Usually presents as bright red or maroon blood in the stool hematochezia.
We got a story from a very relieved parent about this.
Yes, about their toddler, Ben. Around age 2, he started having this painless, bright red bleeding in his diapers. Really scary.
I can imagine.
Multiple ER visits. Finally, they did a specific scan, a technetium 99-meter protectinatate scan, the Meckel scan. It lit up, showing that ectopic gastric tissue.
Ah, so it found the pouch.
Found the pouch with the acid-producing tissue. The doctor explained it was this leftover bit from development causing the bleeding. Surgery removed the diverticulum, and the bleeding stopped.
That fits the rule of twos perfectly, doesn't it? 2% of the population, 2 feet from the ileocecal valve, 2 inches long, symptomatic by age 2, 2 types of ectopic tissue.
It really does, a classic presentation.
Okay, next condition, Hirschsprung disease.
Another congenital issue, usually diagnosed very early.
The mechanism, loss of function mutation in RET leads to failure of neural crest migration and lack of ganglion cells enteric nervous plexuses in distal colon. Bit of a mouthful.
Let's unpack it. It's a birth defect. The key is the lack of specific nerve cells, ganglion cells, in the very last part of the colon.
Why are those cells missing?
It's due to a failure during development. Neural crest cells, which normally migrate down the gut to form these nerve plexuses, don't make it all the way to the end, often linked to a mutation in the RET gene.
And without those nerve cells?
That segment of the colon can't relax properly. It stays tightly constricted, so stool can't pass through that affected segment. It backs up behind it.
Causing a blockage in a newborn.
Yes, the classic sign is a newborn failing to pass their first stool, the meconium, within the first 48 hours of life.
We heard from parents who went through this.
A heartbreaking story initially. Their baby, Leo, didn't pass meconium. Days went by, his belly got huge and firm. he started vomiting.
All signs of obstruction.
Exactly. Doctors suspended Hirschsprung, explained it like a section of his bowel just didn't have the wiring to work. The definitive diagnosis came from a rectal suction biopsy.
What did the biopsy show?
It showed the complete absence of those crucial ganglion cells in the tissue sample. A barium enema can also help by showing that narrow segment and the dilated bowel behind it.
So what's the treatment?
Surgery. They have to remove the aganglionic, non-functioning segment of the colon and connect the healthy bowel further down. After surgery, Leo started thriving.
A tough start, but hopeful outcome. More common in boys and associated with Down syndrome too, right?
That's correct.
Okay, let's shift to cancer development. The Adenoma-carcinoma sequence in colorectal cancer.
Right. This describes the most common pathway for colon cancer development. It's a multi-step process involving genetic mutations.
And the mechanism describes these steps. Loss of APC, decreased intracellular adhesion, increased proliferation, leads to KRAS mutation, unregulated intracellular signaling, then loss of tumor suppressor genes, TP53 DCC.
So it starts with normal colon cells. The first hit is usually a mutation in the APC gene. Think of APC as a gatekeeper that controls cell growth.
Losing APC lets cells grow uncontrolled.
Exactly. It leads to increased proliferation, cells don't stick together properly, and you get a small, benign growth, an adenoma or polyp. That's step one.
But it doesn't stop there.
No. The next common step is a mutation in the KRAS gene. KRAS is involved in signaling pathways inside the cell. Mutated KRAS leads to constant growth signals, even when there shouldn't be.
Making the polyp bigger and more abnormal.
Yes. Then, later hits involve losing tumor suppressor genes, like TP53, the guardian of the genome, and DCC. Losing these removes important brakes on cell growth and allows the adenoma to progress into a full-blown invasive carcinoma.
It's a cascade of genetic changes.
A step-by-step progression. That's why screening is so important. You can catch and remove the polyps before they go through all these steps and become cancer.
We got a story from a family about this. A cautionary tale.
Yeah, about their grandfather, late 60s, very private man. Started getting really tired, pale, lost weight, strange bowel habits.
Subtle changes may be easily dismissed.
Could be. He was found to have iron deficiency anemia, which is a huge red flag for colon cancer, especially in older adults. A colonoscopy found a large tumor.
And the doctor explained the sequence.
Yes, explained how it likely started as a tiny polyp years ago. Then mutation by mutation, APC loss, KRAS activation, TP53 loss, it snowballed into cancer. The family realized earlier screening, removing that initial polyp, could have prevented it all.
Sobering. Colonoscopy is really the gold standard for diagnosis and screening.
Absolutely, though other screening tests like FIT are also available.
Okay, let's talk about the liver again. Fibrosis in cirrhosis.
We touched on cirrhosis earlier, but this focuses on how the scarring actually happens.
The mechanism listed is just two words. Stellate cells.
And those two words are key. Hepatic stellate cells are specialized cells that live in the liver. Normally, they're quiet storing vitamin A.
But when the liver is injured.
When there's chronic liver injury from alcohol, viruses like Hep C or B, fatty liver disease, whatever the cause, these stellate cells get activated.
Activated means?
They transform. They stop storing vitamin A and start producing massive amounts of collagen and other extracellular matrix proteins, basically scar tissue.
So they're the main drivers of the fibrosis.
They are the primary culprits. This excessive collagen deposition leads to the widespread scarring, the fibrosis that distorts the liver's architecture, messes up blood flow, and impairs function, leading to cirrhosis.
We had a listener story that illustrates this progression.
Right. This was Sarah, who had hepatitis C for many years. Started noticing the signs of liver failure, jaundice, spider angiomas, ascites, leg edema, even hepatic encephalopathy with confusion.
All signs the liver isn't working.
Exactly. Hospital workup confirmed cirrhosis. The imaging showed that bumpy, scarred liver. The doctors explained that those stellate cells activated by the chronic Hep C infection had laid down so much scar tissue it was choking the liver.
Can it be reversed?
Advanced cirrhosis is generally considered irreversible, though treating the underlying cause can sometimes halt progression or lead to some regression of fibrosis in earlier stages. Liver biopsy is the definitive way to stage the fibrosis. Liver transplant is the only cure for end-stage cirrhosis.
Okay, next. Reye syndrome. A really scary one, especially concerning kids.
Yes, rare but incredibly serious.
The mechanism. Aspirin decreases beta-oxidation by reversible inhibition of mitochondrial enzymes.
Let's break that down. Reye syndrome happens almost exclusively in children or teenagers who have a viral illness, like the flu or chickenpox, and are given aspirin.
Why aspirin?
Aspirin, in the context of these viral infections in kids, messes with mitochondria, the powerhouses of the cell. Specifically, it inhibits enzymes needed for beta-oxidation, which is how cells break down fats for energy.
So it disrupts energy production.
Severely. This causes widespread mitochondrial damage, hitting the liver and brain particularly hard. You get acute liver failure and massive brain swelling, encephalopathy.
A listener called in with a story about this. Very cautionary.
Extremely. It was about their 7-year-old daughter, Sarah, got the flu. They gave her children's aspirin. She seemed to be getting better.
False recovery.
Exactly. Then suddenly started vomiting nonstop, became confused, irritable, lethargic. Her eyes looked vacant, rapidly progressing encephalopathy.
Oh.
Rushed her to the hospital. Doctors were immediately asking about aspirin use during the viral illness. Diagnosis: Reye syndrome. Explained how the aspirin and virus combo had attacked her liver and brain, causing mitochondrial dysfunction.
Devastating for the parents.
Absolutely. A stark reminder why you never give aspirin or aspirin-containing products to children or teens with viral illnesses. Use acetaminophen or ibuprofen instead. Management is supportive care in the ICU.
Crucial public health message. Okay, related to liver failure again? Hepatic encephalopathy?
Right, a major complication of advanced liver disease.
The mechanism. Cirrhosis causes portosystemic shunts, leading to increased ammonia metabolism. Seems like a typo, maybe increased ammonia levels.
Yeah, that's likely it. Let's rephrase. Cirrhosis causes portosystemic shunts leading to decreased ammonia clearance and thus increased circulating ammonia. Basically, in severe liver disease like cirrhosis, the liver is too damaged to do its job of filtering toxins from the blood.
Especially ammonia.
Ammonia is a key one, produced by bacteria in the gut. Normally, the liver converts it to urea to be excreted. But with cirrhosis, blood often bypasses the damaged liver through abnormal vessels, portosystemic shunts.
So the ammonia doesn't get cleared.
Exactly. It builds up in the bloodstream, travels to the brain, and disrupts brain function. That's hepatic encephalopathy.
Leading to neurological symptoms.
Yes, a whole range, from subtle things like mood changes, confusion, sleep problems, all the way to severe confusion, lethargy, coma, and the classic physical sign is asterixis.
That liver flap.
That flapping tremor, yeah. When the patient holds their hands out, they can't maintain a sustained posture, and the hands flap down.
We had a caregiver describe this.
Yeah, their mother had cirrhosis from Hep C, started acting really strangely confused, mixing up words, irritable, and she had that uncontrollable hand flapping, the asterixis.
How did the doctors explain it?
They diagnosed hepatic encephalopathy. Said her brain was essentially being poisoned by toxins, especially ammonia, that her failing liver couldn't clear because of those shunts.
Was the treatment?
Mainstays are lactulose, which helps trap ammonia in the colon, and rifaximin, an antibiotic that reduces ammonia-producing gut bacteria, and importantly, identifying and treating any precipitating factor, like infection or GI bleeding.
Okay, let's move to alpha-1 antitrypsin deficiency. This one hits both the liver and lungs.
Right, a genetic disorder with a dual impact.
The mechanism. Misfolded proteins aggregate in hepatocellular ER, leading to cirrhosis. In lungs, decreased alpha-1 antitrypsin leads to uninhibited elastase in alveoli, causing panissonar emphysema.
Okay, so two things happening because of one faulty gene. Alpha-1 antitrypsin, AAT, is a protein made mainly in the liver. Its job is to protect tissues, especially the lungs, from damage by enzymes like elastase.
But in this deficiency?
The AAT protein is misfolded because of the genetic defect. In the liver, these misfolded proteins get stuck inside the liver cell's endoplasmic reticulum, ER. They aggregate, build up, and damage the liver cells over time, leading to inflammation, fibrosis, and eventually cirrhosis. You might see PAS-positive globules on biopsy.
And the lung problem.
Because the misfolded protein is stuck in the liver, not enough functional AAT gets released into the bloodstream to reach the lungs. In the lungs, elastase, an enzyme that breaks down elastin, is normally kept in check by AAT. Without enough AAT, elastase runs wild.
Destroying lung tissue.
Exactly. It breaks down the elastic fibers in the alveoli, the tiny air sacs. This leads to emphysema, specifically panissonar emphysema, meaning it affects the entire acinus.
We heard from someone whose sibling had this.
Yeah, their brother Mark, only 45, started getting really short of breath, coughing, wheezing, classic emphysema symptoms, but he wasn't a smoker. That's a big clue. Early onset emphysema in a non-smoker.
Then the liver problem started.
Yes, he became jaundiced. Signs of liver failure. Tests showed low serum AAT levels, and genetic testing confirmed the deficiency, likely the PZ phenotype.
How did the doctor explain the double hit?
Explained that the faulty protein was gumming up the works in his liver, causing cirrhosis, and because it wasn't getting to his lungs, they were being chewed up by unchecked elastase. A devastating double blow.
Treatment options.
For the liver, it's supportive care, ultimately liver transplant for end-stage disease. For the lungs, stopping smoking is crucial, and AAT augmentation therapy, IV infusions of functional AAT protein can help slow the progression of emphysema.
Okay, next genetic disorder, Wilson disease. This one involves copper.
That's right, a problem with copper metabolism.
The mechanism. Mutated hepatocyte copper-transporting ATPase, ATP7B on chromosome 13, leads to decreased copper incorporation into epoceruloplasmin, decreased copper excretion into bile, decreased serum ceruloplasmin, and increased copper in tissues and urine.
Okay, so the root cause is a faulty gene, ATP7B, on chromosome 13. This gene codes for a protein that acts like a copper transporter in liver cells.
What does this transporter normally do?
Two key things. It helps attach copper to a protein called epoceruloplasmin to make ceruloplasmin, which carries copper in the blood, and it helps excrete excess copper from the liver into bile.
So if ATP7B is mutated,
both processes fail. Copper doesn't get incorporated properly into ceruloplasmin, so serum ceruloplasmin levels are low, and copper doesn't get excreted into bile effectively.
meaning copper builds up.
Exactly. It accumulates to toxic levels, primarily in the liver, brain, and the corneas of the eyes.
Causing damage in those organs.
Yes. Liver damage ranging from elevated enzymes to hepatitis to cirrhosis. Brain damage causing neurological problems like tremors, movement issues, and psychiatric symptoms like depression or personality changes, and eye changes.
The eye changes are pretty specific, aren't they?
They're very.
Yeah.
The classic sign is Kaiser-Fleischer rings, greenish-brown rings of copper deposited in the cornea. You also see high levels of copper excreted in the urine over 24 hours. That triad, low ceruloplasmin, high urine copper, Kaiser-Fleischer rings, is diagnostic.
We got an email describing a young adult with puzzling symptoms.
Right, Alex, 22 years old, started becoming clumsy, dropping things, handwriting changed, speech slurred, also became irritable, withdrawn.
Could easily be mistaken for something else initially.
It was. They thought maybe psychiatric issues. But then an eye exam revealed those Kaiser-Fleischer rings. That was the key.
Moment.
Definitely. Confirmed Wilson disease. The copper overload was poisoning his brain and liver. Treatment involves lifelong chelation therapy drugs like penicillamine or trientine to remove copper and sometimes zinc to block absorption.
Okay, another overload condition, hemochromatosis. But this time, it's iron.
Yes, iron overload, usually hereditary.
Mechanism. HFE mutation on chromosome 6 leads to decreased hepsin production, increased intestinal absorption, resulting in iron overload. Increased ferritin, increased iron, increased total iron binding capacity, increased transferrin saturation.
Wait, TIBC should be decrease in iron overload, shouldn't it? Transferrin saturation is increased?
You're absolutely right. Good catch. Let's correct that. Resulting in iron overload, increased ferritin, increased iron, decreased total iron binding capacity, increased transferrin saturation. My apologies.
Yeah.
The key is that transferrin, the iron transport protein, gets highly saturated.
Okay, so the HFE gene mutation on chromosome 6 is the usual cause. In hereditary hemochromatosis, yes. This mutation leads to the body producing less hepcidin. Hepcidin is the master regulator hormone for iron.
What does hepcidin normally do?
It acts like a brake on iron absorption from the gut and iron release from storage cells. Low hepcidin means the brakes are off.
So the body just keeps absorbing too much iron.
Precisely. Way more iron than needed gets absorbed from the diet, and it builds up over time in various organs.
Which organs are most affected?
Liver is a big one, leading to hepatomegaly, cirrhosis, even liver cancer. Pancreas, causing diabetes, sometimes called bronze diabetes because of the skin color change. Heart, leading to cardiomyopathy. Joints, causing arthropathy, especially in the knuckles. And skin, causing that bronze or grayish pigmentation.
We heard about an Uncle Frank with this.
Yeah, listener story. Uncle Frank, late 40s, developed diabetes, had that weird tan or bronze skin color, always tired, aching joints.
Sounds like the classic symptoms.
It really was. A sharp doctor put it together, suggested genetic testing for the HFE mutation, and diagnosed hemochromatosis. Lab tests would show that high ferritin and high transferrin saturation, often 50%.
How did they explain the iron buildup?
Said his body was basically hoarding iron due to low hepcidin, letting it pile up and damage all those organs. The treatment sounds almost medieval.
Phlebotomy. Just Removing blood.
Exactly. Regular blood removal is the most effective way to get rid of the excess iron. And it works. Uncle Frank felt much better.
Simple but effective.
Okay.
Next, gallstone ileus.
An interesting and somewhat uncommon complication of gallstones.
Mechanism. Fistula between gallbladder and gastrointestinal tract allows stone to enter gastrointestinal lumen, obstructing ileocecal valve, narrowest point.
So this usually happens with a large gallstone that's been sitting in the gallbladder for a while, maybe causing chronic inflammation.
And it erodes through the wall.
Yeah, it can actually erode or burrow right through the gallbladder wall and into an adjacent part of the bowel, most often the duodenum, creating a fistula and abnormal connection.
So the gallstone escapes into the intestine.
Correct. Now you've got this typically large stone tumbling down the small intestine. It travels along until it reaches the narrowest part.
The ileocecal valve, where the small intestine beats the large intestine.
That's the spot. It gets stuck there, causing a mechanical small bowel obstruction. That's gallstone ileus, an ileus, or blockage, caused by a gallstone.
We heard from a family member about their grandmother.
Right. She'd had known gallstones for years, but kept putting off surgery. Then one night, severe, crampy abdominal pain, vomiting, belly blew up like a balloon, couldn't pass gas or stool.
Classic signs of a bowel obstruction.
Textbook. An X-ray showed dilated loops of small bowel, but also something unusual. Air in the bile ducts, pneumobilia. That's a big clue for gallstone ileus. Means air from the intestine tracked back up the fistula into the biliary tree.
So the imaging confirmed it.
A CT scan is usually best. It showed the obstruction, the fistula, and the culprit gallstone stuck at the ileocecal valve. She needed surgery and enterolithotomy to remove the stone and relieve the obstruction.
Wow. Ignoring gallstones can have serious consequences.
It certainly can.
Okay, let's talk about acute cholangitis.
Another serious biliary issue. An infection.
Mechanism. Biliary tree obstruction leads to stasis bacterial overgrowth.
Pretty straightforward. Cholangitis is an infection within the bile ducts themselves. It happens when something blocks the flow of bile out of the liver and gallbladder.
Like a gallstone getting stuck in the common bile duct.
That's the most common cause, yes. But it could also be a stricture or a tumor compressing the duct. The point is, bile flow is obstructed.
And blocked bile leads to infection.
Right. Bile backs up, becomes stagnant stasis. This creates a perfect breeding ground for bacteria, usually gut bacteria like E. coli, that ascend up the duct system. They multiply, causing infection and inflammation within the ducts.
Sounds painful and dangerous.
It is. It's a medical emergency. The classic presentation is Charcot's triad.
Right upper quadrant pain, fever, and jaundice.
Exactly. If it gets really severe, you might see Reynolds pentad, which adds altered mental status and shock to the triad. Lab tests show signs of biliary obstruction, high alkaline phosphatase, bilirubin, and infection, high white blood cell count.
A listener told us about their friend David.
Yeah, David had been having some indigestion, right-sided pain, but ignored it. Then one night, spiking fever, felt awful, skin turned yellow, the full Charcot's triad.
So they suspected cholangitis right away.
Yes. Doctors figured a gallstone was blocking his common bile duct, causing bile backup and infection. The priority was urgent biliary decompression.
How do they do that?
Usually with ERCP endoscopy, where they can go in, visualize the ducts, remove the stone, maybe place a stent, plus 4V fluids and strong antibiotics. Once the infection cools down, they'd likely recommend gallbladder removal if stones were the cause.
Critical to act fast.
Okay.
Next up, acute pancreatitis.
Intense inflammation of the pancreas.
Mechanism. Autodigestion of pancreas by pancreatic enzymes. Sounds self-destructive.
It literally is. The pancreas makes powerful digestive enzymes like amylase and lipase to break down food in the intestine. Normally, these enzymes are made in an inactive form and only get activated once they reach the duodenum.
But in pancreatitis,
Something triggers these enzymes to become activated while still inside the pancreas. The most common triggers are gallstones passing through and blocking the pancreatic duct temporarily, or heavy alcohol use.
and activated enzymes inside the pancreas are bad news.
Very bad. They start digesting the pancreas tissue itself, autodigestion. This causes massive inflammation, swelling, and excruciating pain.
Describe the pain.
Typically severe, constant, boring epigastric pain right in the upper middle abdomen that often radiates straight through to the back. Nausea and vomiting are also very common.
We had a story about someone experiencing this.
Yes, after a big fatty meal, which can sometimes trigger it, especially if gallstones are involved. Intense epigastric pain going to the back, couldn't stop vomiting.
How was it diagnosed in the ER?
Clinically based on the pain plus blood tests. Serum lipase levels were sky high, typically more than 3 times the upper limit of normal. Lipase is more specific than amylase for pancreatitis.
And the explanation.
Doctors diagnosed acute pancreatitis, explaining that his own digestive enzymes had essentially attacked his pancreas due to premature activation. Management is primarily supportive.
Meaning?
NPO, nothing by mouth to let the pancreas rest. Lots of 5E fluids to prevent dehydration and complications. Pain control. And treating the underlying cause once stable, like removing the gallbladder if gallstones were the issue. Severe cases might show Cullen's or Gray-Turner's sign, indicating hemorrhage.
Okay, let's move to a condition affecting newborns, the Rh hemolytic disease of the newborn.
Right, an issue of blood type incompatibility between mother and baby.
Mechanism. Rh-negative mother forms antibodies, maternal anti-D immunoglobulin G, against red blood cells of Rh-positive fetus.
So this happens when a mother is Rh negative, meaning her red blood cells lack the Rhd antigen, and she conceives a baby who is Rh positive, inheriting the Rhd antigen from the father.
Is the first Rh-positive baby affected?
Usually not significantly. The main issue is sensitization. During pregnancy, or more commonly during delivery, some of the baby's Rh-positive red blood cells can enter the mother's circulation.
And her immune system reacts.
Yes. Her Rh-negative immune system sees the baby's Rh-positive cells as foreign and produces antibodies against the Rhd antigen, specifically IgG antibodies.
What happens in the next pregnancy with an Rh-positive baby?
Those maternal anti-IgG antibodies can cross the placenta and enter the baby's circulation. There, they attack and destroy the baby's Rh-positive red blood cells. This is hemolysis.
Leading to problems for the baby.
Yes. The breakdown of red blood cells causes anemia and jaundice due to bilirubin buildup from heme breakdown. In severe cases, it can lead to hydrops fetalis, a life-threatening condition with massive swelling and fluid accumulation.
A parent shared their experience with their second child.
Right. Their first son was Rh positive, born without issues. But during that delivery, the mother became sensitized. Her second son, Ethan, also Rh positive, was born deeply jaundiced within the first 24 hours.
What happened then?
Nurses recognized the severity. A direct Coombs test on Ethan's blood was positive, confirming maternal antibodies were attached to his red cells. He needed phototherapy for the jaundice and blood transfusions for the anemia caused by the hemolytic disease.
Scary stuff, but preventable, right?
Largely preventable now with RhoGAM injections. Rho-D immune globulin is given to Rh-negative mothers around 28 weeks gestation and after delivery of an Rh-positive baby, or after any potential sensitizing event. It essentially mops up any fetal Rh-positive cells in her circulation before her immune system can make its own antibodies.
Modern medicine miracle. Okay, anemia and lead poisoning.
An environmental hazard causing blood problems.
Mechanism. Lead inhibits ferrochelatase and aminolevulinic acid dehydratase, leading to decreased heme synthesis and increased red blood cell protoporphyrin.
So, lead interferes directly with the production line for heme. Heme is the iron-containing part of hemoglobin, essential for carrying oxygen.
How does lead interfere?
It blocks 2 crucial enzymes in the heme synthesis pathway, ALA dehydratase and ferrochelatase. Ferrochelatase is the final step, inserting iron into protoporphyrin to make heme.
Blocking these enzymes means less heme.
Exactly. Less heme production leads to less hemoglobin, resulting in anemia. Because there's less heme, the red blood cells are often smaller and paler, microcytic, hypochromic anemia.
And that other part, increased protoporphyrin.
Since ferrochelatase is blocked, the precursor molecule, protoporphyrin, builds up inside the red blood cells because it can't have iron added to it.
We had a story about a young child, Mikey.
Yes, 4-year-old Mikey became irritable, tummy aches, falling behind developmentally. His mom noticed him chewing on old windowsills.
A classic source of lead paint chips in older homes.
Exactly. A routine blood test showed a high lead level. The doctor explained the lead was messing up his red blood cell production by blocking those enzymes needed for heme.
Did they see anything specific on the blood smear?
Yes. Often you see basophilic stippling tiny blue dots within the red blood cells, which are clumps of ribosomes. It's characteristic, though not exclusive, to lead poisoning.
Treatment.
First, remove the source of lead exposure. Then, chelation therapy, using drugs like Succimer or EDTA to bind the lead and help the body excrete it. Plus, supportive care for the anemia and other symptoms like lead colic or neurological issues. Burton line on the gums is another possible sign.
Okay, let's talk about anemia of chronic disease.
A very common type of anemia, often seen in hospitalized patients or those with long-term illnesses.
Mechanism. Inflammation leads to increased hepcidin, which decreases release of iron from macrophages and decreases iron absorption from gut.
So the key driver here is chronic inflammation. Think conditions like rheumatoid arthritis, chronic infections, inflammatory bowel disease, even cancer.
How does inflammation cause anemia?
The inflammation triggers the liver to produce more of that hormone we mentioned earlier, hepcidin.
The iron regulator.
Right. In this context, high hepcidin levels act to restrict iron availability. It blocks iron release from storage cells, like macrophages that recycle iron from old red blood cells.
So iron gets trapped inside cells.
Yes. And hepcidin also reduces iron absorption from the diet in the gut. The net effect is that even if the body has iron stores, that iron isn't accessible for making new red blood cells in the bone marrow.
Leading to anemia even with normal or high iron stores.
Exactly. That's the hallmark. Unlike iron deficiency anemia where iron stores, ferritin, are low, in ACD, ferritin is often normal or high, but serum iron is low, and the total iron binding capacity, TIBC, is also low or normal because the body is actively restricting iron movement. The anemia itself is usually normocytic, normal-sized cells, but can become microcytic over time.
We heard from someone whose grandmother had this.
Yes, grandmother with long-standing rheumatoid arthritis, always fatigued, found to be anemic. Her iron levels were lowish, but her ferritin was high.
The key diagnostic clue?
It was. Doctor explained it was anemia of chronic disease, directly linked to her RA inflammation. Her body was basically hiding the iron away because of the inflammation, making it unavailable.
So iron supplements wouldn't help much.
Generally not, unless there's also a coexisting true iron deficiency. The main treatment for ACD is to treat the underlying inflammatory condition. Sometimes erythropoietin-stimulating agents are used, especially in kidney disease.
Makes sense. Okay, next. Glucose-6-phosphate dehydrogenase G6PD deficiency.
An inherited enzyme deficiency affecting red blood cells, X-linked, so primarily affects males.
Mechanism. Defect in G6PD leads to decreased nicotinamide adenine dinucleotide phosphate, NADPH, decreased reduced glutathione, and increased red blood cell susceptibility to oxidative stress.
Okay, G6PD is an important enzyme inside red blood cells. Its main job is to produce NADPH.
What's NADPH needed for?
NADPH is crucial for regenerating another molecule called reduced glutathione. And reduced glutathione is the red blood cell's primary defense against oxidative stress damage from reactive oxygen species.
So if G6PD is deficient,
you don't make enough NADPH, which means you can't regenerate enough reduced glutathione. The red blood cells lose their defense against oxidative stress.
what happens when they encounter oxidative stress?
They get damaged and break down prematurely, hemolysis. People with G6PD deficiency are usually fine until they're exposed to something that causes significant oxidative stress.
Like certain drugs or foods.
Exactly. Classic triggers include sulfa drugs, certain antimalarials like Primaquine, dapsone, severe infections, and famously, fava beans. That's called favism.
A listener shared a story about their nephew, Omar.
Yes, Omar, 10 years old, Mediterranean background where G6PD deficiency is more common. Healthy kid, got strep throat, was given a sulfa antibiotic.
One of the triggers.
Right. A few days later, he suddenly became extremely tired, pale, skin and eyes turned yellow, jaundice, and his urine was dark like cola, hemoglobinuria. Classic acute hemolytic anemia.
What did the doctors find?
They suspected G6PD deficiency because of his ancestry in the sulfa drug trigger. Explained his red cells lacked the enzyme needed to handle the oxidative stress from the drug, causing them to rupture. Blood smears show Heinz bodies, clumps of damaged hemoglobin, and bite cells where the spleen had removed those Heinz bodies.
How was it managed?
The main thing is avoidance of known triggers. Acute hemolytic episodes are usually self-limiting once the trigger is removed. Supportive care, maybe transfusions if severe. The enzyme assay to diagnose it should be done weeks after an episode, not during.
Good to know. Now, sickle cell anemia.
A major inherited hemoglobin disorder.
Mechanism. Point mutation causes substitution of glutamic acid with valine and beta chain. Low oxygen, high altitude, or acidosis precipitates sickling. Deoxygenated hemoglobin S polymerizes, leading to anemia and vaso-occlusive disease.
So it all starts with a single tiny change in the DNA for the beta-globin part of hemoglobin. A point mutation swaps one amino acid, glutamic acid, for another, valine,
creating abnormal hemoglobin.
Hemoglobin S. Exactly, HbS. Now, HbS behaves normally when it's carrying oxygen. But when it releases oxygen in conditions of low oxygen, dehydration, acidosis, infection, high altitude, it changes shape.
How does it change?
Deoxygenated HbS molecules stick together, forming long, rigid rods or polymers inside the red blood cell. These polymers distort the cell into a stiff crescent or sickle shape.
And these sickled cells cause problems.
Two main problems. One, they're fragile and break down easily, leading to chronic hemolytic anemia. Two, they're stiff and sticky, and they get stuck in small blood vessels, blocking blood flow.
That blockage is the vaso-occlusion.
Yes, causing vaso-occlusive crises, episodes of severe pain. It can also damage organs over time due to lack of oxygen. Stroke, acute chest syndrome, a leading cause of death, damage to bones, a vascular necrosis, spleen damage.
Ah, the autosplenectomy.
Right. The spleen gets damaged from repeated sickling, eventually becoming fibrotic and non-functional. This increases risk of infection with encapsulated bacteria. You see Howl Jolly Body's nuclear remnants on the blood smear because the spleen isn't removing them.
We heard from a parent about their daughter, Maya.
Yes. Maya's first crisis was dactylitis, painful swelling of hands and feet at just 6 months old. Doctors explained how that single amino acid swap caused her red cells to sickle in low oxygen, clogging vessels and causing pain.
How do they manage it?
It's complex. Managing pain crises is key. Hydroxyurea is a mainstay medication. It increases production of fetal hemoglobin, HbF, which interferes with HbS polymerization and reduces crises. Avoiding triggers, staying hydrated, vaccinations, penicillin prophylaxis in kids are all crucial. Stem cell transplant can be curative for some.
A lifelong challenge. Okay, 2 rare platelet disorders next. First, Bernard-Soulier syndrome.
Right. An inherited problem with platelet adhesion.
Mechanism. Decreased glycoprotein IB leads to decreased platelet to VWF adhesion.
So platelets need to stick to the site of injury to start forming a clot. The very first step involves platelets sticking to von Willebrand factor, VWF, which acts like glue on the damaged blood vessel wall.
What allows platelets to stick to VWF?
A protein complex on the platelet surface called glycoprotein IB, GPIB. Think of it as the platelet's receptor for VWF.
And in Bernard-Soulier.
There's a genetic defect causing a lack or malfunction of GPIB. So the platelets can't stick properly to VWF at the injury site. Adhesion fails.
Leading to bleeding.
Yes. Moderate to severe mucocutaneous bleeding, nosebleeds, gum bleeding, heavy periods, easy bruising, prolonged bleeding after cuts or surgery. Starts early in life.
What do the labs show?
Characteristically, you see giant platelets on the blood smear, macrothrombocytopenia. The platelet count might also be low, thrombocytopenia. The key diagnostic test is platelet aggregation studies.
What do those show?
They show impaired platelet aggregation specifically in response to an antibiotic called ristocetin. Ristocetin normally causes VWF to bind GPIB, inducing aggregation. Since GPIB is deficient, this test fails. Aggregation to other agonists like ADP or collagen is usually normal.
We had an email about a boy named Meckel.
Yes, terrible nosebleeds, easy bruising from minor bumps. Doctors noted the lowish platelet count, but were struck by the huge size of his platelets. The ristocetin aggregation test was abnormal, confirming Bernard-Soulier. His platelets just lacked that essential GPIB sticky protein for VWF.
Treatment mainly platelet transfusions.
For severe bleeding, yes, it's an autosomal recessive disorder.
Okay, similar but different. Glanzmann thrombasthenia.
Another inherited platelet function disorder, although autosomal recessive.
Mechanism. Decreased glycoprotein IBVEA leads to decreased platelet-to-platelet aggregation, defective platelet plug.
So after platelets initially stick to the vessel wall, which is normal in Glanzmann, unlike Bernard-Soulier, the next step is for them to stick to each other, platelet aggregation.
What mediates platelet-to-platelet sticking?
The key player is another protein complex on the platelet surface, glycoprotein IBEA, GPI-IBEA. When platelets get activated, this receptor changes shape and binds fibrinogen, which then acts like a bridge, linking adjacent platelets together.
And in Glanzmann?
There's a defect in GPI-IBEA, so fibrinogen can't bind properly and platelets fail to aggregate with each other. They can adhere to the wall, but they can't build up a stable platelet plug.
Also causing severe bleeding.
Yes, similar pattern of mucocutaneous bleeding as Bernard-Soulier, starting in infancy or childhood. Cuts just bleed and bleed.
How do the labs differ from Bernard-Soulier?
This is crucial. In Glanzmann, the platelet count is typically normal and the platelets are normal size. The key difference is in the aggregation studies.
What do they show here?
Platelets fail to aggregate in response to almost all standard agonists, ADP, collagen, epinephrine, but aggregation in response to ristocetin is normal because GPIB and VWF interaction is intact.
We heard about Isabella, a cousin of a listener.
Right. Lifelong issues with bleeding from minor cuts, frequent nosebleeds, normal platelet count puzzled doctors initially. Specialists did the aggregation tests, found that pattern no aggregation to ADP collagen, but normal response to ristocetin, diagnosed Glanzmann. Her platelets lacked the GPI-BA glue needed to clump together.
Again, platelet transfusions for severe bleeding.
Yes, that's the main treatment. Sometimes recombinant factor VI is used.
Okay, finally, a true emergency. Thrombotic thrombocytopenic purpura, TTP.
Yes, TTP is life-threatening, a microangiopathic hemolytic anemia.
Mechanism. Defects in ADAMTs13 leads to large von Willebrand factor multichromatins circulating, causing excessive platelet clumping, small blood clots, and damage to red blood cells.
Okay, ADAMTs13 is an enzyme. Its job is to chop up very large multiseromers of von Willebrand factor, VWF, into smaller, less sticky pieces as they're released into the blood.
What happens if ADAMTs13 is deficient?
Usually due to an autoantibody inhibiting the enzyme. Without functional ADAMTs13, these ultra-large, super sticky VWF multiprimers circulate freely.
And they cause problems.
Big problems.
Yeah.
They spontaneously bind platelets, causing excessive platelet aggregation and the formation of microthrombi, tiny clots in small blood vessels all over the body.
What are the consequences of these microthrombi?
Two major things. First, they consume platelets rapidly, leading to severe thrombocytopenia, very low platelet count. Second, as red blood cells try to squeeze past these clots in small vessels, they get sheared apart, causing microangiopathic hemolytic anemia, MAAA.
You see fragmented red cells on the smear.
Exactly. Schistocytes are a hallmark finding. The classic presentation is often remembered by the pentad F8RN, fever, anemia, MAHA, thrombocytopenia, renal insufficiency, and neurologic symptoms like confusion, seizures, stroke, though not all five are always present.
We heard from someone whose friend had a rapid decline.
Yes, Mark. Became acutely confused, forgetful, developed fever, petechiae, small red spots from bleeding under the skin due to low platelets.
Sounds like the pentad unfolding.
It was. Hospital labs showed near zero platelets, severe anemia with schistocytes on the smear, diagnosis, TTP. Doctor explained his ADAMTs13 enzyme was deficient, likely autoimmune, causing platelets to clot wildly in small vessels, damaging organs and shredding red cells. PT-PTT coagulation tests are typically normal, distinguishing it from DIC.
What's the treatment? It sounds urgent.
Extremely urgent. The definitive treatment is plasma exchange, plasmapheresis. This removes the patient's plasma, containing the autoantibodies and large VWF multimers, and replaces it with fresh donor plasma, containing functional ADAMTs13. Corticosteroids are also used.
And the crucial point about platelets.
Platelet transfusions are generally contraindicated in TTP. Giving more platelets can actually fuel the fire, worsening the microthrombi formation. It's a critical point. TTP requires immediate recognition and plasma exchange.
Wow. What a journey through these conditions.
Yeah.
From adaptive cell changes in Barrett's to genetic errors in Wilson's or sickle cell to these catastrophic cascades like TTP.
It really highlights the incredible complexity and sometimes the fragility of our physiology, doesn't it? How a single protein defect or an environmental trigger can have such profound effects.
And hearing these stories, these personal accounts, makes the science so much more real and memorable. It's not just pathways on a chart.
Absolutely. It connects the mechanism to the human experience, and it reinforces how important diagnosis, understanding the why, and appropriate management truly are.
A huge thank you to everyone who shared their stories with us for this deep dive. You made this possible.
Indeed. So, maybe a final thought for you, our listener. Reflect on that interconnectedness. How a problem in one system, like the liver's handling of copper in Wilson's, manifests in the brain and eyes. Or how an immune response to gluten and celiac devastates nutrient absorption. What connections or patterns stood out most to you across these diverse conditions, all illustrating the body's delicate balance?
Something to ponder. Until next time, stay curious.